Good evening, everyone, and a warm welcome to each of you, whether you are present tonight or listening to tonight's recording when convenient. I understand we have a lot of international registrants, some folks as far away as China, so a very special welcome to you. For those of you who are joining us for the first time, my name is Maria Pascuzzi. I am the director of Spirit Alive, which is a ministry supported by my congregation, the Sisters of St. Joseph of Brentwood, New York. We can provide these programs thanks to the support of the sisters and through donations. Please allow me to begin, as I usually do, with a few announcements. First, tonight's presentation is being recorded and within 72 hours will be posted on the Spirit Alive YouTube channel, along with the recordings of all of our other presentations. Feel free to listen again and know that if you have a conflict and can't be present for one of the AI seminars or for one of our mini courses, you can always view the recording. But please be patient. It takes a little time for our tech assistant to get that posted for you. Also, I found out earlier this evening that Verizon cellular service is affected and is down. I don't know, it's up again. But if you know anybody who couldn't get on tonight for some reason related to cellular service or their internet, please remind them that they can see the recording at a later date. If you have questions, you can submit them throughout the presentation by typing them in the Q&A box at the bottom of your screen, or I don't know if you have iPad, it might be elsewhere. And at the end of the presentation, our presenter will answer as many questions as possible. Finally, Spirit Alive welcomes any donation you can make to support our programs. You can find donation information and instructions online where you first registered for this program. So in previous webinars, we have considered the impact of AI on human self-understanding, social relations, and education. Tonight, our webinar focuses on AI's impact on healthcare and the ethical questions it raises. You may have already had the experience of having one of your screenings or diagnostic tests reviewed and analyzed by AI. Admittedly, AI's increasing use in healthcare can offer significant advantages in the identification and the treatment of diseases. But its use also comes with a number of significant concerns, which will be considered tonight, not the least of which is what this means for the patient-doctor relationship, which has already been reshaped or redimensionalized by the use of virtual visits. To consider the various complexities surrounding the use of AI in healthcare, we have the honor of having with us this evening Professor Paul Scherz. Dr. Scherz began his career in science with a BA in molecular and cell biology from UC Berkeley in 2001, and then a Ph.D. in genetics from Harvard in 2005, followed by a postdoctoral fellowship at UC San Francisco. He then received a master's degree in theological studies and a Ph.D. in moral theology from Notre Dame University. That Ph.D. was in 2014. After teaching at the Catholic University of America for a number of years and spending 1 year at University of Virginia as a visiting fellow, Dr. Scherz returned to Notre Dame University in 2024, where he's currently the Our Lady of Guadalupe Professor of Theology and also teaches in Notre Dame's Institute for Ethics and the Common Good, where he is the chair of the Notre Dame/IBM Tech Ethics Lab program. Professor Scherz's scholarly publications cover pages. His multidisciplinary research and writing agenda focus on questions and issues in theology, science, medicine, and technology. Suffice it to say that he is the author of at least 3 monographs, numerous book chapters, dozens of articles and essays published in academic journals, and dozens more in popular media. He is also the recipient of various honors and research grants, including a sizable grant from the John Templeton Foundation supporting his work on risk in ethics, published by Georgetown University Press, entitled Tomorrow's Troubles: Risk, Anxiety, and Prudence in an Age of Algorithmic Governance. Started to read that book today. I recommend it. Go to Amazon. In it, Professor Scherz invites readers to focus on discerning God's will in the present rather than dwelling on a future we cannot control. Along with our previous presenters, Dr. Scherz is a member of the AI Research Group for the Center for Digital Culture of the Dicastery for Culture and Education of the Holy See. Despite a hectic teaching, publishing, and lecturing schedule at both national and international conferences, he still makes time to share his knowledge with parish audiences and tonight with our spiritual, alive virtual community. So thank you, Paul, for being with us, and a warm welcome as you join us on this stormy, wintry, snowy night from South Bend, Indiana.
Thank you so much for that warm introduction, and thanks to all of you for joining us this evening. So I'm going to be talking about healthcare. So continuing this series to look at the ethical impacts of AI on healthcare, right? And AI is already having a huge impact on healthcare, and it's only going to grow. So this last year, there was $1.4 billion spent on healthcare AI. Over the last 3 years, there's been $30 billion invested in startups that are engaged in AI and healthcare. And whenever I talk to people at hospitals, they're always trying to figure out how are they going to implement more AI in the clinic. So this is something that is going to just keep growing. And it's affecting Catholic healthcare as well. Already in 2019, there was somewhat of a kind of a problematic revelation that Ascension Healthcare and Google were working together on kind of trading on health files or electronic medical records of their patients without the patient understanding, right? And a number of nonprofit healthcare institutions have gathered together to form companies like Truvita, including Catholic health systems, which gathers lots of data to use to train AI. Right, so AI is affecting healthcare. There's a lot of opportunity here, but also a lot of possible problems. And this is an area, as I'm sure you've heard in one of the previous talks, in which Pope Leo has asked moral theologians and the church to really engage. His first address to the College of Cardinals, he offers to everyone the treasury of the church's social teaching in response to what he calls another industrial revolution that pose new challenges for the defense of human dignity, justice, and labor. And that's certainly what's going on in healthcare. And he also calls us in a discussion with the Italian bishops to use the church's anthropological vision, our vision of what it is to be a human person, as an essential tool for pastoral discernment. So how do we use AI well throughout our world? And especially tonight, we'll talk about in the clinic. Now, I'm going to follow Pope Leo's suggestion and suggest that we do look at the roots of Catholic bioethics as it lies in our understanding of the human person, right? And the person as made in the image of God, and use that as kind of a fundamental tool for discerning which uses are problematic and which uses really can be something that enhances human flourishing. So I'll spend the first few minutes talking about the image of God, the kinds of ethical tools of discernment that arises from that, and how we can use that will set up how we can use it in healthcare. Then the next part of the talk will be looking at some of the issues that arise in terms of justice and the use of in these algorithms themselves. So issues like bias, issues like privacy, issues of what are called AI alignment, things in which you can have the tool itself can go awry. And then the last part of the talk will be looking at that relational aspect, the practitioner-patient relationship that's so important for healing. So even just visiting a doctor has an important effect on kind of how the patient does. There's a placebo effect that comes from visiting doctors, right? And look at how AI could both support that relationship, but also could undermine it and de-skill the doctor's ability to really care for patients. Right? So to start the body of the talk, right, Catholic ethics is fundamentally rooted in its vision of the human person, its anthropology, the logos it has of the human, anthropos. Right? And this is foundational to Vatican II. Gaudium et Spes, that document really kind of sets up our ethics and our vision of society in terms of the human person as understood in light of Jesus, right? So all ethics flows from respect for the dignity of the person as the person is made in the image of God. And the image of God is so central that it's right at the first chapter of the Bible. In Genesis, uh, we read that God created mankind in his own image. In the image of God, he created them, male and female, he created them. Right. So when the church reads the Bible, it doesn't read the creation narratives as something where kind of describing scientifically what happened over 7 days. Right. The church reads the creation narratives in Genesis as allowing for a long period of evolution. But what the creation narratives do tell us, and what it's so important to tell us, is they tell us about the human person. They tell us something essential about humans, who human beings are, and how people relate to God, right? And this relationship is grounded in this creation in God's image. Okay, so people have dignity because they're made in this image of God. But like lots of theological concepts and concepts central to our faith, things coming out of the Bible. The image of God means a number of different things, right? I mean, so in comparison, think of the idea of the body of Christ, which can be in both, Christ's historic body, as in the incarnation, in which he lived, died, and was raised. It can mean the Eucharist, where we receive Christ's body every week, and it can mean the church as a whole, in which each of us are members of the body of Christ, right? So similarly, the Imago Dei has many different meanings, has many different aspects of it that are all connected together, but they bring important pieces to the table, right? So, like one of the important aspects is that it indicates a dignity to the human person and a certain sanctity to human life. And we see this in Genesis 9, a couple of chapters after the first chapter of Genesis, when after the covenant that God, after the flood in which God destroys the world, but aside from Noah and his family, when Noah emerges from the ark, God makes a covenant with them in which he shows the rainbow as a sign he won't destroy the world. But also, Noah agrees to follow some commandments. And one of those is that whoever sheds human blood, by humans shall their blood be shed. For in the image of God has God made mankind. What that means is that the image means that human life is sacred. No one should take innocent human life. Right? And the other thing that comes out of this dignity is that there's an equality between people, that we each have this image of God. So each person's life is equally sacred. And the church has drawn from this the idea of human rights, these rights to life, to things necessary for life, like healthcare. And it's something that we have equally. And so people need to be treated equally. The other thing that being in the image of God raises, all right, so yeah, just to finish off with that anything that denies that equality, and this is where we're going to talk about bias, anything that denies that equality can be held to be against human dignity. The other thing that the image of God says is it suggests something about us, that we have certain capacities that are similar to God's. And most fundamentally in the theological tradition, along with what the relationality we'll talk about in a minute, is that we have reason and free will. John Paul II, in his bioethics encyclical, says the biblical author sees as part of this image spiritual faculties, which are distinctively human, such as reason, discernment between good and evil, and free will. The ability to attain truth and freedom are human prerogatives, inasmuch as man is created in the image of the Creator, God who is true and just. So God has created an orderly, rational world. Right? God did not just create a random, chaotic thing. The world that we see is ordered, and we can understand it through science, through math, and that's wonderful. And we can also, God created the world freely, and we too have a freedom of action to act for good. Right? So one of the concerns that can be raised with AI is when it replaces human thought. Right? or undermines human freedom and its ability to act in the world, that can raise problems for human dignity. Right. Now, of course, this freedom isn't arbitrary. It's made for a purpose. So Gaudium et Spes, the document of the Second Vatican Council, says, "For God has willed that man remain under the control of his own decisions, so that he can seek his Creator spontaneously and come freely to utter and blissful perfection through loyalty to him." We have freedom, we have reason for a purpose, and that purpose is to serve God, right? And in part, it's also we serve God in many ways throughout our life by serving others, those around us. So if we want to translate that into medicine, is that medical practitioners should be able to practice their medicine using their responsible clinical judgment, right, within the bounds of their conscience. And patients should be able to have autonomous decisions respected as long as they comply with the moral law. So this point of freedom is very important, and it should be a responsible freedom. And we see this focus on action in another aspect of the image of God. So classically, this was described in terms of dominion, right? Because in Genesis, right before the creation that I discussed, the verse says, God said, "Let us make mankind in our image and our likeness so that they may rule over the fish in the sea, birds in the sky, livestock and wild animals, and all creatures." Right? There's a rulership of humanity. Now, many people have been concerned with this idea of dominion because it suggests that we own the world, we have property, and we have control over it in many ways. But biblical scholars have suggested that's a misunderstanding of what it means to have dominion. Recent scholars have interpreted this more in terms of a stewardship, that God has set us up to rule in the sense of rule in God's name. If we go to Genesis chapter 2, God commands Adam and Eve to till and keep the garden, right? So not only using the garden by tilling it for agriculture, but keeping it, right? Preserving it. So we're not able to just destroy the environment around us, but we need to take care of it, right? And the stewardship plays into bioethics. It means that we can't do whatever we want. God is the sole Lord of life, so man can't do with our lives as we will because we get our life from God. It also means that the things we have, like private property, is subordinated to what God wants us to do with it, to use it for the common good, to steward it for God's service. Okay, so God calls us to action, and we should have the rights to act freely, and we should have spaces that are made so that we can act freely. Now, the last aspect that I want to talk about in terms of the image of God is that the image of God indicates that we are social creatures. So, in that moment of creation, we weren't created just on our own. We are created as male and female. We are created in a relationship already, right? And the second chapter of Genesis again says that it's not good for man to be alone. We are created to be with others. And this isn't something that's new with the Christian tradition. The Greeks also recognize that, as Aristotle says, humans are political animals. We're social creatures, right? I mean, so family, I mean, we can't live without our family. We can't survive on our own out in the woods. We need, I mean, someone could for a while, but if you're a young child, you're going to need to be raised by others. We all will need care from others when we're sick. And if we really want to flourish, we're going to need others to help us. Right. So there's an aspect of justice here that we are tied together in communities and we need to seek our good together. And this in Catholicism is called the common good, that our individual good is tied to that of everyone else's because we're social creatures. And in this, we image the Creator because the Christian God is a Trinity. It's triune God. So there's three persons there existing in relationship, Father, Son, and Holy Spirit. And in a very different way, we also are called to live in that relationship. Now, one of the things that come out of this is a focus on what's called the preferential option for the poor. So, on the one hand, we're all equal, and the other hand, we are all meant to flourish together. Now, in unjust social situations, the people who are likely to be worst off are those who are poor, are those who are vulnerable. So, if we really want to respect the image of God, respect rights, respect that equality, and respect that have a shared social common good, we need to pay attention especially to those who are suffering, to those who are poor, those who are most likely to be victimized, right? Especially when we design technologies and social institutions. And this is indicated by the prophets who suggest that we need to have special care for the poor in the Old Testament. But in the New Testament, we also see in Matthew 25, there's this great apocalyptic vision that Jesus describes of the end of the world. And in that vision, he separates the sheep from the goats. Um, with the goats on his right going to heaven and the goats on his left going to damnation. But the thing that is kind of indicated as the reason they get their kind of final reward is focused on very concrete care of those who are suffering, bodily care, so feeding the hungry, but especially caring for the sick. Right? And what Christ says is, Amen, I say to you, whatever you did for one of these least brothers of mine, you did for me. So in serving others, we serve Christ. Right? So Christianity took this kind of vision of the human person as having dignity, even in their poorest and most suffering mode, and really made medicine a central apostolate of the church and a central way to image Christ. Um, it- so already we see one of the important ministries that Jesus did was a healing ministry, and that continued in the early church. And in many ways, we hear stories in the Bible of miraculous healing. But what was also going on at the time was some very kind of practical, pragmatic care of the sick, right? Just kind of the normal care that one can offer. And we know that in the third century, there was a huge plague that swept the Mediterranean, the Cyprianic plague. And we know that Christians stood out to the pagans around them because they took such care of the sick, not just those who were Christians, but everyone. Similarly, we know that Alexandria, they had organized ambulance services to care for the sick. The first hospitals developed in a Christian setting, with monasteries developing them and being developed by kind of bishops to care for the poor and the ill in their areas. And this monastic kind of focus that religious orders have driven healthcare continued throughout the medieval period and the modern period. Right. So that now we have a huge Catholic apostolate in medicine. Right. So the sisters have did an amazing job in the US of building up hospitals and other ways to care for the sick. So 600 hospitals and 1,600 other facilities in the US are Catholic. So other facilities would be things like nursing homes. One in seven US patients are cared for at a Catholic facility. Right? So, and if we look worldwide, the missionary efforts have meant that 26% of healthcare facilities worldwide, 5,300 hospitals, are Catholic. So we have built up this commitment to caring for the sick. And not only in a Catholic institutions, but many healthcare providers are religious themselves, going out into the world to live their vocation in medicine, serving the sick, right? So you're serving the poor, you're recognizing the dignity in others when you engage in healthcare. Right. So two things that I want to highlight in this healthcare mission. The one is the one that I already mentioned, how it serves as an aspect of the preferential option for the poor, right? So it is a way to heal, to serve those who are least among us. But the other aspect is something that comes out of for in the relationship that the individual doctor or nurse, therapist can have with the patient. Now, recent church writings have described how the individual medical practitioner, when they engage the sick person, are in many ways enacting the parable of the Good Samaritan. Now, if you remember the parable, so there's a man who's left for dead by robbers by the side of the road. A priest and a Levite pass by, but it's only the Samaritan, who should be an enemy of the Jewish people, who actually stops and takes care of the person, provides bodily care, puts the person on to heal the wounds, puts the person on his animal and takes them to an inn where he gives money for his continued care. Right. And so there's many things that this parable mean, but one of the aspects that people have said is that, and Pope Francis especially highlighted this, is that this is a demonstration of how we should behave in society. When we see a suffering person, we should go and engage them, right? Be ready to see their suffering. So the Samaritan was moved viscerally, right? We should be responsive to the suffering and go and care for that person. Many people who write on medicine have described the clinical encounter can be something of the very similar way. So Edmund Pellegrino, a great Catholic doctor and bioethicist, describes how all of medicine emerges out of the encounter between the doctor and the suffering person. And the medical practitioner is the one who steps forward and makes a profession that they are willing to help. And so that personal encounter that emerges in that relationship is incredibly important from a moral and even a theological perspective, right? So, going to be talking about the preferential option for the poor, and then also this kind of aspect of the Good Samaritan when we get into the kind of further ethical discussions. Now, moving on into this discussion of AI in medicine. AI can make a great contribution to medicine. It can be a real aid to healthcare, right? So it can give better diagnostics and prediction. Right? It can provide better health. It can give the kind of monitoring that allows public health to function better and to restrict diseases. And if we really want to give a preferential option for the poor, it should be the best possible kind of healthcare, which AI can help to provide. In terms of the relationship, people like Eric Topol, kind of a doctor who does a lot of thinking about medical policy, he has high hopes that this can actually serve that relationship by taking care of charting, billing, and other routine tasks, and by helping the doctor in a way and serving as an assistant that can help provide more time to the doctor and address staff shortages. Right? So a lot of people are very optimistic about AI. And one of the other modes is it can help do a totally new version of medicine. So many countries around the world have been developing what's called precision medicine. And this is drawing on the wealth of information that we have through the genetic and genome projects that's been running over the last 25 years, taking all of that genetic information, combining it with information that lies in electronic medical records, and using that to predict what kind of risks someone might have down the road. How do we treat better? What are the kinds of treatments that will help people? Now, this kind of data analysis is only possible with AI or other kinds of advanced data analytics. Now, already people are seeing kind of good outcomes come out of this through when it's tied to oncology, to cancer treatment. They're sequencing cancer tumors and using data analytics to suggest what are the treatments that might work best given that genetic sequence, genetic mutations in that tumor. And so governments have been running huge projects on this. So the All of Us program is the one that has been running by the National Institutes of Health in the US, and they want to recruit 1 million people, look at their genome, sequence their genome, look at their medical charts, and take interviews, have them run Fitbits, and use this all as a way to kind of get a better picture of what are the kinds of factors that can lead to ill and better health. Okay, so there's a lot of good things it can do, but there are also dangers, right? So on the one hand, there's these dangers that affect the preferential option for the poor, or they're part of the programs itself. And these are things like bias, the difficulty of thinking, applying these information we're getting from these large studies to individuals, and concerns over privacy. But they also will have effects on the healing relationship, right? But before we draw into it, I mean, first I want to just review something that you've probably heard in previous talks about how AI actually functions. Now, one of the things that I was told very early when I started my work in AI about 10 years ago by an AI researcher is that AI is fundamentally statistics. When you're thinking of the kind of modern machine learning, what all of these large language models that are being used now or other kinds of tools are used, what they're doing is they're taking vast amounts of data that we have on the internet or in electronic medical records and churning through them to discover correlations, right? And then using statistical correlations and then using these correlations to make predictions. Right. So if we wanted, for in medicine, it would be something like you look at people with these kinds of symptoms, you know they're correlated with certain kinds of, looking at tons of people with those symptoms, you learn, the machine learns that they're correlated with a certain kind of disease, and that helps them in the future to predict that people with those symptoms will have this disease. I mean, this is what happens with Netflix or YouTube or any of these search algorithms. They look at things that you've watched in the past and then kind of make correlations to things, other videos that are similar to them or that other people who have liked in the past, and then predict something new to you, right? So AI is statistics. It looks at data, draws statistical correlations, and then makes predictions from them. The problem is, as many people have noted, that predictions can go wrong. They can go deeply wrong in ways that will intensify the unjust features of society. One of the first major books to make this point was by Cathy O'Neill, a mathematician who described this as kind of, there can be possibly weapons of math destruction, as she called it. Right? And I want to go through some of these ways in which AI, because of its statistical nature, just because of how it functions, if it's built incorrectly, it can lead to great injustice and problems for the poor in healthcare. I'll start with a non-healthcare example just to kind of, because it's easier than talking about genetics, but use a non-healthcare example and then dive into the kind of, to a number of healthcare examples, right? So, one of the ways that that AI can lead to injustice is through bias, right? And Joy Buolamwini, who was at the time an MIT graduate student, discovered this through a really interesting study on facial recognition systems. Because she was realizing that facial recognition systems that were out there couldn't recognize her face. Some of them didn't even recognize that her face was that. It couldn't indicate that there was a face there when she was looking at the camera. So she was curious about this. And so she looked at three top image facial recognition system and showed them a bunch of different faces, right? So what these things are generally doing are looking at features like kind of the distance between eyes and distance between different features and kind of determining how are some different faces similar. So when she divided up pictures into sets that were of darker skinned males, some for darker skinned females, and lighter skinned males, lighter skinned females. And she ran all of these through these facial recognition systems. And what she found is they were really good for lighter skinned males. If you look at the middle column there, they're almost 100% accurate there, 99 to 100%. For lighter skinned females and for darker skinned males, they were still in the 90s, less good. They didn't work as well, but largely in the 90th percentile. But if you looked at when she ran darker skinned females through them, they got really, really bad, like only 2/3 accuracy, right? So even the most accurate was less than 80% accurate. So why was this? Well, what she discovered was that the sets of pictures that they used to train these AIs, the pictures that they fed into the machine so that would learn the correlations, didn't have many pictures of women, of darker skinned people, or and especially of women of color, right? So they didn't have these pictures. The machine never, therefore, never saw them, and thus the machine never learned to make the correlations that would help it to identify the faces of darker skinned female. And this is what's called a problem with training data, right? If you feed um, bad data into a system or incomplete data into a system, then it's going to give you bad and biased results, right? So AI develops through machine learning, it trains on this mass amount of data, but if it doesn't have the pictures of people you want to identify, of people who are like the people you want to identify, then it will never learn to identify them. Right. Now, luckily, this is a fairly easy thing to fix. You just include more diverse pictures in the training data, and that can help it make those kinds of distinctions. But we see similar problems in healthcare data, right? When these precision medicine programs, when they first started, most of the data and electronic medical records that they were getting were from upper middle class people of European descent. So they're only going to learn the health problems and the genetic makeup of people of European descent. I mean, so why were they only these people? Well, these were the only people who are like freely giving away their DNA to research programs, right? So a lot of minority communities are very skeptical of these programs for good reason because of past injustices in research programs like the Tuskegee syphilis study. Um, and problems with, you might have heard of Henrietta Lacks. So there's lots of good reasons why the minority groups are somewhat skeptical of research enterprises, but they just weren't giving the data to them, and thus they didn't that these early programs weren't making algorithms that were very good for minorities, right? That means, or people who are poor, or these other kinds of groups. So one of the solutions would be a more diverse data set. Now, the problem is that's hard to do, but these programs have kind of done that with more outreach, more recruitment from different populations, just to make sure they have kind of good training data. But one of the other problems, that doesn't solve everything because the more diverse the training data, it can become more difficult to identify if you're looking for a genetic cause, genes of interest. You just have a much noisier set of data. And therefore, because it's so diverse, it can become more difficult to find the important signals in that noise. I mean, so for this reason, a lot of the early um, genome projects that were trying to do this precision medicine things and interpret the genomic information looked at very small populations. So one of the first companies doing this was Decode Genetics, which bought the health records and DNA of Iceland, right? So why did they do this? Well, because Iceland is a small island nation. It was settled by about, I think, 400 families about 1,000 years ago. It's had very little immigration. And so it's kind of very homogenous, and therefore any genetic cause of disease stands out really well, right? The problem is that you can't divide groups into those kinds of small population groups very easily. There's not very many people that are places that are as homogenous as something like Iceland is. Generally, we have very mixed populations, and people have very mixed ancestries. Now, one of the things that people have tried to do is to come up with algorithms and programs that are kind of more racially specific. But the issue that arises with that is race isn't a biological category. We've known this, geneticists have been saying this for 60 years. Race is a sociological category. right? So some of the earliest evidence they use for this is that there's more genetic diversity within racial groupings than between them, right? And Africa is the most genetically diverse continent of all. And if you look at most places, there's a lot of intermixings between different people. So, I mean, if you've gone to your ancestry.com or one of these kinds of ancestry genetics, for a lot of people, you've got like sources coming from all over, right, going into your heritage. That's especially true of a place like the US, which has tons of immigration. So it's really hard to come up with algorithms or AI that are kind of targeted towards specific groups. And thus, sometimes it can be hard to come up with things that are as accurate for everyone, right? So, one of the examples that I frequently use is of this breast cancer trial that where they were trying to come up with a tool that would help them figure out um, should be more screened through mammograms, right? So they wanted to get more accurately, like who should they recommend for mammograms and who's at lower risk, so don't need mammograms as frequently. And they came up with a risk score that was dependent upon your racial group. So they had a white risk score, a Hispanic risk score, an African American risk score, and they compared this to just the kind of older risk calculator that they were using. Um, the problem was, how do we place people in these different bins? So there was one woman who's it was a really interesting story that she had placed herself in a Hispanic risk group because it's Hispanic ancestry because she was from Mexico. But when she was given a lower risk score, she was trying to figure out then whether she should just name herself Hispanic or European because her parents had moved from Spain to Mexico. And so should she identify as Hispanic or as white? And there's no answer to that question because these are somewhat arbitrary social categories. They're not biological categories. Right? So AI can create these issues of kind of how do you figure out relating an individual to these larger populations? Like what data do we use? How do we use it? Even when you have a good diverse data set, it can still be problematic because there can be injustices built into the data set. Now, one of the most prominent examples of this was a study done by Ziad Obermeyer, who's a public health professor who does a lot of work on AI. And what he was looking at was um, these risk calculators. So what these were trying to do is saying that people who go to the hospital a lot, they was trying to predict people who are going to be really costly for the system. So something like half of Medicare costs is charged to 2% of the Medicare population or Medicaid population, I think is similar. And these are people who have lots of different conditions. So they might have heart disease, diabetes, and high blood pressure, as well as having a mental illness, maybe having social issues like not being homeless or having substance use issues, right? So the health systems really want to focus on these people to make sure that they're not driving up costs by continually coming to the emergency room. And one of the ways they did this is by developing these programs that target these people. They give them an actual care coordinator who talks to their different doctors and makes sure as their pharmacist is explaining which prescriptions they need and there's not drug interactions. They might give them social support, like figure out how do they get Section 8 housing by sending a social worker to help them, giving them some kinds of funds to get to their appointments, right? So these are great programs. But they had to calculate who would be at highest risk, who are the people that they should spend this extra money on to try to save money. Now, what you see in this graph here is that this calculator was systematically biased against Black patients. Now, why was that, right? I mean, so here we go. So if you look at the vertical axis, the y-axis, that is the number of chronic conditions that a person has. So like, well, chronic condition is something like diabetes. The x-axis, the horizontal axis is what level of risk you have. The purple line is for black patients that were screened, and the yellowy orangish line is for white patients who were screened. You can see that at every risk score percentile, you had a black patient had to have a higher number of chronic conditions to score the same as a white patient. Um, and to get to the point where you actually get into the program, you need to have almost a full another other chronic condition, right? So have like also heart disease on top of everything else. Now, why was that? Well, he looked at the algorithm and he figured out it's because the people aim to the thing that the programmers told the AI the algorithm to optimize for was who would cost the most, right? And which makes sense because if you're going to a hospital a lot, you're going to cost a lot of money. But the problem that arises out of this is that in the past, this is all using historical data. In the past, black patients had less money to spend on healthcare because of historical reasons of kind of problems with getting employment due to discrimination, due to the problems of redlining, not building household wealth. And for all these reasons, they've had less money, less insurance coverage in the past, and therefore they look like they're cheaper. And so if you're optimizing to pick out who is going to be the costliest patient, black patients are never going to look as costly as a white patient because in the past they had less money to spend, right? So it's some problem of the metric they used. Right? And this is what's more generally called the alignment problem. So there's two things going on. So, right, so there's this structural historical problem of the data that's in the data, right? So you're translating sinful structures into today's world. But there's also what's called an alignment problem, is that they were picking the wrong goal to optimize. Instead of optimizing to find out who's going to be the sickest patient, they were optimizing for who's going to be the costliest patient. Now, one of the problems is how do we specify our goals for a machine? So sickness just seems is somewhat vague, right? You know, and how do you judge who is sicker than others? You have to find some kind of quantitative metric. But this is difficult. I mean, we have a difficulty translating our goals into machines. And this, you know, people have talked about this in terms of games and things where you'll have AIs do totally weird behavior. Like, you know, in a racing game, they'll kind of just spin in a corner. Why is that? Well, because the machine was optimized to maximize points, and there you could gain points in that corner. So there was maximizing something that was not your true goal. Okay. Now, with the Obermeyer example, he was helped by the fact that this was somewhat of an older, dumber kind of algorithm. But today's algorithms, he wouldn't be able to even tell why the algorithm was going bad because you can't explain how the AI is making the correlations that they are. AIs are what's known as a black box. They are so complicated and they're just looking at so much data that even their programmers don't understand how they're picking out the patterns that they are, right? We can't explain it. And that creates problems because you can't know why it's going wrong, or even sometimes if it's going wrong, if it goes wrong. Now, but it's also the power of the AI is that it can find patterns that we can't, but it raises these issues for justice. Okay. And the last issue of justice is about privacy, right? Probably every healthcare company you're interacting with is using medical records to train AIs in some way, right? This is something that is a concern because once the information of that is drawn into the AI, there's ways that you can pick out that information or figure things out about people by engaging with the AI. So this raises great privacy concerns. Okay, now I want to turn to the last section, which is looking at the healing relationship. So one of the ways, one of the most important things in the medical relationship is the doctor and the doctor's ability to be compassionate with the patient. There's a huge placebo effect that comes from just visiting a doctor, right? And as I said, this is a way in which it's also an ethical aspect of medicine because it is a way for doctors and nurses and others to act out this role of the Good Samaritan, to have a true encounter with another. And this is Pope Francis has called us to build these ethics of this culture of encounter. Right. Now, there are many ways in which AI can assist in fostering the doctor-patient relationship, right? I mean, so they can help the doctor in the doctor's tasks through diagnostics. So it can be an assistant in that. But it can also help the doctor build these relationships more directly. Right. So one of the things that has been really impressive recently, and which healthcare practitioners are loving, is what's called ambient AI or AI scribes. And if you've been to a doctor in the last 15 years, you've probably noticed that have to spend a lot of time looking at the screen, right? So electronic medical records, doctors have to fill in all the little kind of bubbles and forms in the computer, and frequently they have to do this while they're in the middle of a visit. So they can't look at the patient, they have to pay attention to the screen. And that can't but disrupt the doctor-patient relationship because eye contact is extremely important. Um, what these new ambient AI or AI scribes do, though, is that they use AI to record the conversation that goes on between the doctor and patient, to make a transcription of it, and then to analyze it and use that transcript to fill out the medical record, right, and all the notes. Um, so the doctor can trust that the AI is doing it. They don't have to be the one sitting there and filling it out. Right, and doctor still has to check these notes afterwards. None of these are 100% perfect, but it really gives a kind of a tool to help the doctor kind of be able to pay more attention to the patient. This also gives the doctors more time that they can spend with patients because it can reduce paperwork. So these AI scribes can also, when they're embedded in electronic medical records, shoot out medical orders. They can do a lot of the back office tasks like billing. And this is things which take away kind of bureaucratic tasks from the practitioner so that they can focus on caring for the patient, the real kind of ethically important aspect of their lives. Of course, there are dangers to AI. Most straightforwardly is there's the danger of replacing the doctor with a chatbot, right? We've seen just in the last few weeks, OpenAI has introduced a ChatGPT Health, right? Now, and this is just advice, don't kind of rely solely on this for your medical advice. But this is a lot of kind of tech boosters have these dreams of using chatbots in replacement of AI, in replacement of doctors, right? Or even maybe not for the doctor themselves, but for triage nurses or for other kinds of things, right? This would be a grave problem. As Pope Leo said an address he gave to some visiting doctors, dialogue, communication, and physical contact must always be present in the therapeutic relationship beyond the instruments and tools used to treat illnesses. AI can and should be a great help in improving clinical care, but nothing can take the place of the doctor because you are, as Pope Benedict XVI said, reserves of love who bring serenity and hope to the suffering. The algorithm cannot substitute a gesture of closeness or a word of consolation. They cannot provide that true encounter. Now, so we can push back against replacing doctors, right? We don't want to do that, right? That's clearly problematic. But one of my concerns is that even if the AI doesn't replace a doctor, it can still affect them in ways that either undermine their flourishing or undermine their ability to make to make shared decisions with the patients. Now we know that AI is being kind of put into a lot of the electronic medical records now in the form of what's called a clinical decision support system that will kind of suggest things to doctors or tell them when they should consider certain things. And this could be good. I mean, there are things that could help. But the dangers that I see is that this can introduce an increased role for health system management to impinge on the decisions of the healthcare practitioner and of the patient, right? So how might this occur? Um, it can cause it allows for an increased surveillance of workers. Everything is being fed through the computer, and so the management has oversight of everything. It can also, there are threats that um, doctors might be told to follow AI recommendations even if they disagree with them. I've heard anecdote of nurses being told to just follow the AI even if they disagree. Um, Already, doctors have been told that they'll be docked their reimbursement rates if they don't follow certain kinds of guidelines. Um, we could get into a system where, okay, technically the doctor is giving the final word, but if they go against the AI, they might be penalized, right? And even if management not telling them to do this, there could be fears of liability. Um, if the doctor goes against the AI, even if the AI is saying even if it goes against the AI, and if something goes wrong, which will happen in either any case, like whether the AI is making a recommendation or the doctor. In some case, even if everything is happening optimally, there will be bad outcomes because that's just how medicine works. Will the doctor be at increased risk of liability if they have turned down an AI recommendation? And the other concern is that um, medical practitioners will end up being overscheduled because one of the AI things that AI has been used for in a lot of industries, like is kind of maximizing the amount of working hours that people do, so that doctors will have not more time with patients, but less time because they lose the time they gain from kind of someone missing an appointment or something like that, right? And doctors are very concerned about this. So already, Farkerlin, who is a palliative care physician at Duke and a major Christian bioethicist, decries the invisible social engineer standing in the corner of every exam room, armed with a checklist the doctor must follow in order to ensure that she provides quality care that is safe and value-based. Neither patients nor physicians call the shots, right? So neither of them are able to act out of their responsible agency, their reason and free will, right? Justin Mutter, a palliative care doc at University of Virginia, says that much of clinical reasoning is already transitioning away from providers' judgments towards statistical and algorithmic computation. And this really raises dangers for the dignity of work. Workers have rights because they have a call towards responsible stewardship to have good working conditions. And this includes a dignified work environment, which is not just a not dangerous work environment, but a work environment where people can act autonomously, right? Now, it becomes really hard for doctors to challenge AI sometimes because they might not understand why the AI is making the decision. Now, they can judge that the AI is making the wrong decision based on their own judgment, but they can't challenge AI's reasoning because, as I said, it's a black box. The last danger is that the medical staff might just end up acquiescing to AI no matter what. There's this tendency that's called automation bias. And this has been seen in piloting most of all, where pilots, because they become reliant on automated pilots, they lose the skills to do landing or can't recognize when an instrument is going wrong. And thus, they end up putting too much trust in a system. And when something goes wrong, it can lead to a disaster. So we have plane crashes, many plane crashes due to pilots over trust in automated systems that end up not working. right? And this can happen in medicine when the doctor can miss information that doesn't fit the computer's recommendation or just lose their own skills for interpretation and is no longer acting in relationship or as a kind of true, responsible person with reason and free will. Okay, so what I would say, so I don't want to deny that AI has great promise for medicine. It can help provide better treatment and it even can help foster relationships between the doctor and the patient. But there are things that must be done when they're implemented to prevent bad things from happening. We need to figure out how to prevent bias. We need to determine how to maintain personalized care even when you're dealing with population data, and we need to protect the clinician's judgment. Okay. Thank you very much.
Let me just get my audio on. I'm back with you. Thank you, Paul, for that wonderful presentation. Packed. I don't see any questions in the Q&A. I'm sure people are thinking about what you said. I guess I'd like to start with a question or two. In our very first presentation by one of your colleagues, uh, Professor Green out at Santa Clara, one of the first things he showed us is how fallible AI is, right? And he gave us an illustration, which I quote, AI recognizing. It was a it was a it was a it was a baseball in a mitt, and it had recognized for a long time properly. But when a baseball was put in a mitt and those red lines were on the baseballs, the stitches, it thought it was seeing a shark. I think that's what it was. It was very funny. Anyway, so I guess what my question is, with that thought in mind, how can healthcare systems be as insistent or move in the direction of insisting that doctors could be penalized for not following the AI recommendations? I mean, this made me very nervous listening to you tonight with what was put in my mind by Professor Green and what you're saying, because is it or is it not the case? I mean, I guess here's the question. Can AI, with regard to healthcare and diagnostics, be wrong to the degree that it's wrong with everything else? Or is the medical field an entirely different field where AI doesn't really make mistakes?
No, AI will always make mistakes, right? I mean, it's fallible. Well, I mean, everything is fallible. I mean, so this is a great danger that it can have fundamental misreads. And this is especially true in medicine where so much of good clinical judgment depends on getting a total picture of the patient, right?
Mhm.
You have to look at the patient's lives. What can they actually do? If they're a truck driver, maybe like having something where they have to take medicine 4 times a day at exact times is not something they can do. You need to look at the social situation and understand where their medicine disease is coming from and how to modify that, right? There's so much medicine that is so particular that you can't quantify in the way that AI needs to function well. Um, yeah, so AI will get things wrong, and as we said, there's training data can be wrong. We know that it's being trained on medical literatures that we know are fallible. It's being trained on medical charts that we know are very poorly put together, right? So if ask any doctor about medical charts, and they'll tell you hilarious stories about, kind of like horrible records of like clearly wrong things in medical charts, right? So a lot of that, yeah, that exists, but that's overcome because of the prudent judgment of the clinician. But machines don't have that kind of judgment that they can do
Mhm.
when they're
Mhm.
trained. So yeah, they can go wrong. Now, why are health systems so insistent? Now, I want to say that these are dangers, and some I've heard stories of some that kind of gung ho tech kind of administrators who really want to do this, and a lot of them don't have really good understandings of the fallibility of AI, right? So they're being sold this by some technology company. Now, I want to also say that there's a lot of really good health executives who are thinking through these things and realize that, okay, yeah, we want to really kind of carefully monitor how this is being used, how it's been developed. There's a whole kind of group called the Coalition for Healthcare AI that has developed tools for best practices for kind of judging how these are developed. So there are people who are thinking about that, but is a major danger.
Yeah. We have a question from a retired pediatrician. She said, already evidence had the response to saving 45 minutes a day of charting with scheduling more patients a day unrealistic that after 20 or 25 patients, a practitioner will reread transcripts and correct notes if no notes were taken at the time of visit by the doctor. The writing practice is in itself a critical part of critical thinking regarding diagnosis. I hope Ellen, wherever you are, I hope I got your question. I think we understand the question. So, Paul?
Yeah, no, I mean that's wonderful. Thank you for for including that question. And that is something that's been challenged with this ambient AI and AI scribe that like with education, you think by writing, right? And
Right.
does not writing, will that undermine part of clinical judgment? Um, and I think that could be a real danger. And as I said, that there is evidence that, I didn't know that there was that kind of evidence of the overscheduling. But yeah, as I said, that is a danger. Um, Now, I do want to say that like discussions with physicians have have suggested that they really appreciate these medical scribes, these AI scribes. I think part of the reason is that electronic medical records are such a bad technology. Physicians hate the electronic medical record, right? And so if it was the AI scribe versus writing by hand, like physicians used to do, then maybe you wouldn't have, it wouldn't be good to move to them. The kind of concern arises with, kind of, it seems to save some of the problems with the electronic medical record.
Here's an interesting question. Can or does the church use AI to determine the health of new marriages by creating a database of past marriages to determine if the new marriages will be successful by analyzing the past marriages' longevities based on various criteria such as culture, nationality, age, length, couple have known each other, occupations, education, family, and dynamics? Why?
No, I can say that. I mean, so one of the things is you can come up with statistics and you can give a prediction, but that prediction is only an average for a population, right? And it's going to be saying that like this couple is maybe, 10% more likely than average not to work out. So it can give that kind of data, but every marriage is between two individuals who are using their free will to make their way through the struggles of kind of daily married life, right? So there's the freedom of the couple, but also there's the fact that populations and individuals don't line up very well.
Well, I have a question too. It's come up in my mind listening to other webinars. Uh, Sometimes I think AI is kind of like some of the worst parts of what we do as human beings on steroids. So when I talk to you about, when you talk about, the bias that's there, I mean, as a woman, I've read for years, and I think there are a lot of women in this room tonight, how doctors have ignored cardiac issues with women because they've only used men as their subjects. So we've been kind of doing this without AI for forever, right? So that's my question. Does AI just, when we talk about the drawbacks of AI in terms of bias or especially against the poor, isn't it just the capability that is allowing some of those biases that exist already because we're human beings and that's the way we do things, because we're a patriarchal society, or because we're this kind of society or a racist society? Doesn't it just give us the possibility of making those biases, which are maybe innate within us or inherent, worse? So AI is like our worst instincts on steroids. Does that make any sense?
That's a great point. Yeah. I mean, I mean, you don't want to like romanticize what things were like before when you're dealing with AI. The thing that AI does is it generalizes and kind of accelerates these biases, right? So, I mean, the famous example is the Amazon resume screener, right? Where it ended up biased against women because there's no women in tech, there are very few women in tech. Now, if you just had a person reading these resumes, right, you could always, or if you're a person engaging, the doctor engaging with the person, there's always the moment where the person can break through, have a conversion, have a change, right, or realize this person in front of them is something different, right? The AI will never have that. It will
Mhm,
always just respond to its training data.
mhm. We have a number of other questions. How would medical training need to evolve in order to bolster the ability of doctors to use their agency in situations? How could they build up their interpretation skills and their confidence in their judgment? How does medical education need to evolve given the possible challenges of AI? Can it?
Yeah, no, I mean, I think in we're having trouble with education throughout, like the university, even more broadly, besides just medicine. So, like, this is going to be the major struggle of the next 2 decades, I think, is to figure out how to educate well in the world that we're coming together. I think some of the things with doctors need to do is that they need to understand statistics better. They need to understand a little bit about how AI can work. Um, understand the programs and where they go wrong and how they create problems. I think all of those things need to be integrated into medical education, but also more of a focus on the humanistic side of medicine to show what the doctor, a lot of the things doctors bring that AI can't do. Right. So those are things I would suggest, but I think a lot of it is also going to happen in how do we redesign AI programs so that they do allow for doctors to kind of have that humanistic encounter.
Hmm. And here's a great question. Could AI tell a doctor to stop treatment because of risk slash reward probability?
Yeah, it could. I mean, you would want to, yeah. I mean, so one of the things AI is being used for is kind of to tell drug interactions in pharmacies and things like that. And you could, in theory, you could have the AI tell people to do that. But a lot if you first you have to take a step back to the medical literature. A lot of the medical literature is driven by is funded by pharmaceutical companies whose aim is to increase the amount of medication taken, right? So what I've seen is there's very few studies that actually recommend lowering or removing medications and treatments.
It's great. And a last question here. Are patients being informed about ambient AI, and are they being asked if they consent to having it transcribed during their medical visit? Great question.
So I mean, so this differs from health system to health system. I think in general, from what I've heard, patients are being told when it's being used as a kind of as a scribe, transient AI. It is being used for ambient AI is being used as a scribe. So they are being told this and asked to consent for it. I'm not sure if those consents are kind of full though, because there's a lot of things that come downstream of that is who gets that data? Does a tech company have access to the data from that? What is the data of that conversation being used for? Sometimes even I mean, most of the time the doctor won't know that. Sometimes even, kind of the people who are making the implementation might not look at those kinds of details.
Mm. Well, we're at 8:15. This has been interesting. We've had a lot of interesting conversation, and I thank you. I think everyone who's been part of this. We have a lot to think about tonight, I guess, when it comes to healthcare, because it touches us so personally. It's something that really engages us. I'd like to remind everyone that we have two more webinars on AI in this webinar series. They're coming up in February, one early February. AI is its impact on the environment, and then the concluding webinar where Matthew Godet from Santa Clara is going to try to wrap up everything and look at both the marvels, the menaces, and problems with AI. So, and the benefits. So we don't want to turn this into an apocalyptic experience. We want to look at what's good. The church has always looked at what's good from science and technology and tried to incorporate that without compromising the values that are so important in our tradition. So Professor Scherz, thanks so much for showing up. I know there's a lot of snow in Notre Dame. I hope you don't get barricaded in your house tonight. And to everyone else, good night and God bless. And we say a prayer for all of those people who are suffering tonight, mind, body, and spirit, especially the people who are frightened by what is going on in our world because of ICE. So again, we commend them into the hands of our Lord and ask for his protection for these people and for right judgment and just judgment to prevail. We ask all of that through Christ our Lord. Amen. Good night, everyone. Thanks so much for coming. Good night, Paul.
You.